Let me expressing what an honor is for me to be here as a lecturer in your university in Varna. We were here last year with my colleagues, Włodzimierz Bialik and Paweł Olczyk, last year, doing the work concerning the integration of our pharmacy programs in order to facilitate the exchange students program. We welcome you to our university. We come from the School of Pharmacy with the Division of Laboratory Medicine in Sosnowiec. This is a part of Medical University of Silesia in Katowice. Silesia is an industry region located in the south of Poland, maybe not so charmingly located like yours in the Black Sea, but also very nice city, as you can see. I'm a member of a department of clinical chemistry and laboratory medicine, our scientific interest is focused on the laboratory markers and laboratory medicine biochemical parameters to analyze some diseases and to help diagnosis. In this lecture, I would like to present the most important aspect of renal diseases, and a special attention will be paid to the laboratory markers of the most important renal diseases, such as acute and chronic kidney diseases, and discuss the role that which possibility we have to early diagnosis of these disorders. Let's start with the lecture plan, and the first one I remember some physiological role of kidney and the causes and symptoms of kidney diseases, and then the early markers of acute renal dysfunction and the chronic renal diseases, which is the very important nowadays. Human urinary system consists of two pairs of kidneys, a pair of ureters and bladder and urethra. Kidneys are a pair of bean-shaped organs, small organs, only 11 centimeters long, 6 centimeters wide, and 3 centimeters thick. And they lie on either side of the spine. The right kidney is usually slightly lower than the left because the liver is located in the right side of the body. Despite this very small size, kidneys belong to the mostly vascular organs. This is really important because the renal circulation received around 20% of cardiac output. That means that 1,200 milliliters of blood per minute is received by the kidney. And blood flow through these organs is 5 times greater than blood flow through the heart. This is important to maintain homeostasis, I mean the constancy of chemical composition, the constant volume of the fluid, and the blood pressure. Internally, kidney consists of 3 parts. This is a kidney renal cortex, and renal medulla, and renal pelvis. The first one renal cortex layer is the outer layer, is about 1.5 4 centimeters thick, and all glomeruli responsible for the filtration process, blood filtration, is located in this layer. And the second one, renal medulla, contains renal pyramids responsible for maintaining the salt and the water balance of the blood. The principal structural and functional unit of the kidney is called nephron. Each nephron is composed of two important parts. This is a renal corpuscle with the glomerulus and Bowman capsule when the filtration process occurs, and the second one is a renal tubule composed of different regions, each own important function: the proximal tubule, nephron loop, and distal tubule and collecting duct. Each nephron perform three basic tasks. This is a filtration, which occurs in a renal corpuscle, the reabsorption process, and the secretion. The first one, glomerular filtration, occurs in Bowman capsule, and in 1 minute about 125 milliliters of the blood is filtered out, of only 1 milliliter is excreted as a urine. The second process, tubular reabsorption process, mainly in the proximal tubule, which is called mass reabsorber, and here substances which are needed for the body, such as water, glucose, amino acid, ions like sodium, potassium, chloride, and bicarbonate are reabsorbed. In the loop of Henle and the distal tube, the water and ions are reabsorbed, and the tubular secretion is a process that discharges chemicals which are not needed by the body, and they are secreted into the urine. This is the excess of ions, some nitrogenous waste, metabolic waste, hormones, certain drugs, and also kidney helps to secrete hydrogen ions and potassium ions. As a result of these three processes, the waste are changed into the urine. They are also concentrated in the loop of Henle and a distal weight, and as a result of this process, the urine is formation. This is the first job which is kidney do, maybe not a glamorous job, but like you see, somebody's got to do it. And the other renal functions are related with the influence of blood pH, the maintenance of acid-base balance, the regulation of blood pressure, regulation of red blood cells production, and bone mineral metabolism. The kidney remove major nitrogenous waste such as ammonia, urea, uric acid, and creatinine. Also metabolic waste and drugs. Kidney are able to control the volume of water in the body, and this anti-diuretic hormone and aldosterone helps to proceed this function. The kidney regulate the electrolyte homeostasis, such as ions like sodium, potassium, chloride, calcium, and magnesium. Important role of kidney is the regulation of pH level by the blood. Kidney do it by excretion of acids in a form of hydrogen ions and reabsorption of bicarbonate ions. It's really important function of the kidney. And the next one is a regulation of blood pressure. Kidney control blood pressure by regulated the excretion of sodium ions and the water, as well as by the production of enzymes called renin. The endocrine function of the kidney is to produce erythropoietin. This is the hormone that stimulates production of red blood cells, mainly in response to the low blood oxygen level. The other endocrine function is related with this, with the hydroxylation of 25-hydroxy vitamin D to active hormone calcitriol, 1.25 dihydroxycholecalciferol called calcitriol, as well as by this endocrine function is related with the synthesize the prostaglandins, which regulate the distribution of the blood in the kidney. And metabolic function of kidney are related with glyconeogenesis, degradation of some hormones and drugs, and also participation in creatinine biosynthesis. The increasing number of patients with kidney diseases is the most important reason for why we search a new diagnostic method to early identification of these diseases. To implementation the treatment that will be able to prevent the age and stage of renal diseases. The routine laboratory analysis of renal function is related with the assessment of biochemical markers, which you know very well. This is a creatinine, urea, uric acid, and electrolytes. Creatinine is a breakdown product of endogenous creatinine, which is in the skeletal muscle, and also it could come from the exogenous creatinine, which is ingested in the food. Serum creatinine level is different for men and for women, but they are many functions without the kidney which influence serum creatinine level. This is the amount of protein intake, the liver efficiency, the age and gender, muscle mass, muscle function, composition, and also very important creatinine tubular secretion. This is the cause by the serum creatinine may give false results. More precisely measure of kidney function can be estimated by calculate how much creatinine is cleared from the blood by the kidney. This is referred as creatinine clearance, and it's estimate the glomerular filtration rate, GFR, and GFR can be measured by two ways. Directly measured by collecting urine samples and the blood samples and quantitatively assess the creatinine in the urine and in the blood, or it can be calculated, estimated by mathematical formula using different formulas such as Cockcroft-Gault, MDRD, CKD, API equation, and they are very complicated with different age, gender, race, body mass, albumin, urea. You need these parameters, these variables to assess this GFR by this quotation. GFR. Małka pociwka. GFR is used to monitor the progression of renal disease and to define the stages of chronic kidney diseases. They are the 5 stages of chronic kidney diseases, with the first stage established renal failure. This is very important to estimate GFR, not only look for a serum creatinine, like just serum creatinine may be the same for these 3 people, but when you estimate GFR and adjust the glomerular filtration by the sex, gender, and other factors, the glomerular filtration rate will be different. So it's the better parameter to assess kidney function. Serum creatinine is the changes in serum creatinine occurs when the 50% of kidney function has been lost. This is the the good parameter, but for the late stage of the kidney diseases. So it's another one parameters routinely used in the kidney diagnosis is urea and blood urea nitrogen, which is increased in the kidney diseases or kidney failure. And especially used the blood urea nitrogen to creatinine ratio is important to differential diagnosis of renal diseases. The cause of renal diseases, the urinalysis using a microscopic examination or a dipstick test, and important tests such as quantitative assessment of albumin. We can do it by assess the albumin to creatinine ratio or to albumin excretion rate. This is the albumin quantitatively assessed in the urine sample in time urine selected samples. They occur at the very early stage of renal disorders, and albuminuria is really good parameters. However, current guidelines do not recommend screening for kidney diseases in general population, but only at population who is at high risk for development of chronic kidney diseases. And the initial test for evaluation of GFR will be serum creatinine to estimate GFR and the urine albumin to creatinine ratio. The first kidney diseases which I wanted to talk is this acute kidney injury and the biomarkers which can be related with the diagnosis of this disease. Acute kidney diseases is a sudden loss of kidney excretory function, often with oliguria, which occurs over the course of only hours or days. This is a very dangerous diseases leading to accumulation of nitrogen and metabolic waste and to the deep water electrolyte disturbances. AKI is defined as any of the following. This is maybe a rise of serum creatinine of 1.5 times bisalin, or it could be only the oliguria, urine volume of less than 0.5 milliliters per kilogram per hour for 6 hours. This is a disease which is still misunderstood, misdiagnosed. We're still trying to find effective therapeutic intervention, but still poor outcomes are received. This AKI is frequently seen in hospitalized patients, affecting up to 50% of patients in intensive care units. It's really important problem in these units and is characterized by a rapid decrease of GFR and slow but permanent loss of the most affected nephrons. The main reason for these pathological changes which occur in AKI is the acute apoptosis, acute death of the renal tubule cells caused by the renal ischemia reperfusion injury, such as reduced blood flow to the kidney, or by the septic or toxic kidney damage caused by radiocontest agents, antifungal, antimicrobial, cytotoxic agents, or nephrotoxic drugs. It occurs very quickly. You see, this is a days, sudden initiation, ischemia, initiate these changes. This is extension, maintenance, and many of patients maintain recovery of the kidney function, but some of them remain dialysis dependent. And the causes of acute kidney injury is prerenal, renal, or post-renal. Prerenal, this is not a problem, is with the blood which is entered into the kidney. It's not enough blood to filtrate, to allow filtrate. The renal causes are related with the inflammation, toxins, drugs, and direct damage the kidney. And post-renal, this is sudden obstruction of urine flow due to different causes. This disease is classified by different criteria based on GFR criteria and diuresis. And the early markers of this acute renal failure. It's really important to identify the patients with early phases of these diseases during the phase which is potential to reverse renal injury, and that's why the troponin-like biomarkers has been developed and include neutrophil gelatinase associated lipocalin and GAL, kidney injury molecules, and interleukin 11. They are many of these many biomarkers has getting attention as early indicators because they are increased at very first age of these diseases. Neutrophil gelatinase associated lipocalin we can assess in the urine or in the plasma, and is now this marker has been now globally implemented as a standard clinical laboratory assessment in the early prediction of AKI. Because this occurs really in preclinical stage of this disorder. This is a small molecule which is filtered through the kidney, then this is reabsorbed in the proximal tubule and then secreted in the distal part, but also increase with the urinary tract infection, so it should be careful interpreting this test, but rises rapidly in response to kidney injury and rises in a dose-dependent manner. I mean, it rose proportional to the degree of kidney damage. It's very important, and its clinical significance is related with the early diagnosis of AKI, as well as in the evaluation of progression of the second disease, which causes chronic kidney disease also. And another one parameters, this is kidney injury molecule 1, which is a transmembrane protein expressed in low levels by normal kidney, but overexpressed in response to nephrotic injury. It's also useful in early diagnosis of AKI. And the next one is interleukin 11 excreted by the epithelial cells of proximal tubules at very early stage of AKI. And another one parameters such as sodium hydrogen antiporter 3, structural protein of renal tubule, and important for the sodium transport. The decrease in its expression in the kidney and is a specific marker for acute tubal injury. The beta-2 microglobulin in the urine we can also assess in patients with diabetic nephropathy, cadmium toxicity. Promising new AKI biomarkers include a nephrocheck, which detects together the presence of tissue inhibitor metalloproteinases 2 and insulin growth factor binding protein 7 in the urine, and this is the point of care test which provide a score within 20 minutes, and the score correlates to the patient's risk to developing AKI within the next 12 hours of the test was performed. Maybe we have no such as time. This is the analyzer and test for this point of care tests. And the next disorder is kidney chronic diseases. AKI and CKD are closely related. Each is a risk factor to developing others. So AKI can lead to CKD and inversely CKD to predispose to developed AKI. Chronic kidney diseases is a gradual and a long time permanent loss of kidney function. It's defined by having more than 3 months at least one of the following: evidence of the kidney damage or the decreased GFR. Markers of kidney injury involves albuminuria, and the other one, and decreased GFR less than 60 milliliters. CKD is classified now as one of the civilization illness. Based on the new report, global report, 1 in 10 people in the world have chronic kidney diseases, but many don't know they have it. CKD is a silent disease. Silent, I mean initial stage, are often asymptomatic. They are recognized at the end stage, which are dangerous for patients. CKD is prevalent, is more prevalent in elderly population, but what is important, only 24% of countries reported an active CKD detection program. Nobody diagnosed this, and this is important to diagnose this CKD in an early stage and to perform this laboratory analysis, at least albuminuria and GFR, estimated GFR, and patients who are at least at risk to develop chronic kidney diseases. The main causes of chronic kidney diseases is diabetes as well as hypertension, with both together include 67% of CKD. The other one are related with glomerulonephritis, not diabetic cause, and the interstitial nephritis caused by drugs. And CKD develops gradually, and this is a permanent loss of kidney function. And the main criteria for diagnosing this disease is based on the GFR. GFR and albumin assessment also help to assess the risk of adverse outcome of this disease. The complication of kidney function is related with sodium balance, sodium retention is developed, and volume overload. Potassium excretion is also not proceed, and the hyperkalemia develops, and the other metabolic disturbances such as acidosis and anemia. Here are the symptoms of chronic kidney diseases, which you have to watch on this picture, and the other one, symptoms of chronic kidney diseases. And let's go to the early markers of chronic kidney diseases. This is albuminuria, cystatin C, and neutrophil gelatinase associated lipocalin, and other ones. The most important are albuminuria, and the categories of chronic kidney disease based on albuminuria are also accepted as the earliest marker for nephropathy, and are important to prognosis of and categorize the risk of these diseases. Important marker assessed in serum and urine is a cystatin C. This is protein produced by all nucleated cells at a constant rate, and is freely filtrated and then completely catabolized in the proximal tubules. It's an almost ideal endogenous filtration marker, but costly, less effective than the creatinine. The advantage of the cystatin C is that this marker is not influenced by the changes in muscle mass, can be detected in very early renal impairment, and is not influenced by inflammation. And the disadvantage are smaller but exist. This is increase in plasma concentration with ACE, high biological variability, and cancer, steroid use, and thyroid dysfunction affect the level of cystatin C, but we know that and we have to take into account. Asymmetric dimethyloarginine is also important marker, but assessed in the scientific works. And the novel biomarkers reported to other diseases called primary membranous nephropathy. This is autoimmune diseases characterized by formation of immune complex in glomerular basement membrane, and leads to loss of kidney function. And very well markers to identify this membranous nephropathy are the antibodies against phospholipase A2 receptor and thrombospondin type 1 domain containing 7A. Membranous nephropathy is an immune complex are deposited in the glomerular basement membrane, and the primary cause are idiopathic in many cases of these disorders, and the secondary is related with the malignancy, infection, drug intoxication, and autoimmune diseases. Among them important is the lupus erythematosus. And important is the diagnostic differentiation between these two cases of membranous nephropathy, because this is crucial to the later treatment of this disorder. Disorders, the primary is treated by immunosuppressant, and the secondary, the underlying diseases is treated. And the new urinary marker to predict kidney disease progression is called epidermal growth factor, which help to predict which chronic kidney diseases patients are at risk of kidney progression or kidney failure. But they are new and still not very well studied. And the novel biomarkers are related with the microRNAs and the DNA methylation pattern or assessment, urinary extracellular vesicles, among them the most important are fibronectin, laminin, and glycosaminoglycans assessment. And unique methodologies have been developed in order to assess these new biomarkers, such as proteomics, metabolics, and transcriptomics. And that will be the end of my lecture. Thank you for your attention.